A 4-year-old boy was a diagnosed case of acquired, very severe aplastic anemia. Financial constraints precluded the use of anti-thymocyte globulin. The blood counts after 6 weeks of monotherapy with cyclosporine A, 12 mg per kilogram per day, were still in the range designated as very severe. During this period, he received 4 units of packed red blood cells beside multiple units of platelet concentrates for ongoing bleeding manifestations. A week after the last red cell transfusion, he developed high-grade fever and a maculopapular rash on the trunk with progression to all parts of the body over a period of 48 hours. There were no gastrointestinal symptoms.
The results of investigation were a hemoglobin of 35 grams per liter, WBC count of 1.8 times 10 to the power of 9 per liter, and a platelet count of 7 times 10 to the power of 9 per liter. The absolute neutrophil count was 0.072 times 10 to the power of 9 per liter. Serum bilirubin was 8.4 mg per dl and a conjugated fraction of 50%. There was no transaminitis. The serum alkaline phosphatase level was 22 Ka unit per liter. The skin biopsy showed features consistent with grade 2 graft host versus disease. He was started on pulse methylprednisolone. There was no response. Antibiotics and antifungals were administered as per protocol's guideline for the management of febrile neutropenia. His condition progressively deteriorated and culminated in death after 3 weeks after the onset of graft versus host disease.
With graft versus host disease, graft refers to a section of transplanted or donated tissue like the bone marrow or peripheral blood. And host refers to the tissues of the person receiving the transplant. In this disease, immune cells in the donated tissue attack the recipient's body cells. Normally, the system's job is to fight against anything foreign that might cause harm without harming the body's own cells. To make that work, the immune system cells are trained early on to distinguish the body's own cells called self cells from foreign cells called non-self cells. Recognizing whether the cell is foreign or not involves a set of genes called histocompatibility genes, which makes up the major histocompatibility complex or MHC proteins, which also go by the name human leukocyte antigens or HLA.
In graft versus host disease, there are 3 elements. Graft must contain immune cells. This is usually the case in hematopoietic stem cell transplantations, which contain hematopoietic stem cells that can give rise to all types of blood cells, including immune cells. Typically, hematopoietic stem cell transplantations are needed by individuals whose own bone marrow doesn't function properly, example leukemia. Host immune system must be suppressed so that it doesn't destroy the grafted immune cells, giving the graft immune cells enough time to mount an attack. Host must be immunologically different from donor. In other words, the host histocompatibility antigens, namely the HLA antigens, must appear as foreign to the grafted immune cells.
So shortly after transplantation, the host's dendritic cells, which usually hang out in various host tissue, like the lining of the skin, might pick up antigens from the tissue and travel into the nearest lymph node, where a lot of immune cells coming from the donor live. That's where they meet with helper T cells and present those antigens upon their MHC class II molecules. If the donor helper T cells recognize these antigens as foreign, they differentiate into type 1 helper T cells. Th1 cells then start releasing the cytokines, interleukin-2 and interferon gamma, which help both of them and other T cells in the area proliferate. At the same time, These cytokines induce the expression of more MHC class II molecules on the surface of the host cells, which makes it easier for the donor helper T cells and the host antigen-presenting cells to interact with it.
In addition to helper T cells, there are also grafted cytotoxic T cells circulating in the area. These cytotoxic T cells recognize antigens presented upon MHC class I molecules, which are on the surface of all nucleated cells in the host body. As before, if these antigens are seen as foreign, the cytotoxic T cells get activated and start secreting perforin, which perforate the target cells by forming pores and granzymes to enter the cells, which induces apoptosis or programmed cell death.
The symptoms of graft versus host disease vary widely, depending on the type of tissue affected, and it's not known why some types of tissues, usually the skin, liver, and digestive tract, are affected more frequently and more severely than others, and why there is a correlation with time after the transplant. In the first 3 months following transplantation, there's the acute form of the disease, which typically involves the skin. It causes a painful or itchy rash on the palms of the hands or soles of the feet that can peel or blister and progress to covering the whole body. After the skin, the next most common target is the liver, where the disease is usually asymptomatic, but leads to an elevation in bilirubin, alkaline phosphatase, and aminotransferases like ALT and AST. Acute graft versus host disease can also involve other parts of the digestive system, particularly the distal small intestine and colon, causing diarrhea, intestinal bleeding, and abdominal pain. If graft versus host disease persists for more than 3 months following transplantation, it's considered chronic. Once again, the skin is most commonly affected chronically, and it can cause the skin to thicken. It can also affect the eyes and lacrimal glands, causing a burning sensation and photophobia, or difficulty tolerating bright light. Chronically, the proximal digestive tract can also be involved, particularly the mouth and salivary glands, causing dry mouth, sensitivity to acidic or spicy foods, and odynophagia, or pain when swallowing. Less frequently, chronic graft versus host disease can affect the lungs, causing shortness of breath and cough, and the muscles, causing muscle cramps and weakness.